Okay, gentlemen, please. Keep your mobiles, please. Inside the pocket, please, mobiles, all of you. Gentlemen, stop using the mobiles, please. I hope you are listening to me. Please keep your mobiles inside. Please keep mobiles inside. Okay. Few definitions from another presentation because they make sense here, and then I'll go back to the distal tubule and the collecting ducts very quickly, okay? We have talked about the proximal tubule. We know the meanings of the words filtration, reabsorption, secretion. Are you comfortable with all these words? You know. And you know the processes also which are causing the transports which are causing reabsorption or secretion or other mechanisms which are happening. Look, tubular reabsorption, okay, which is the reabsorption of the tubules. If you think about tubular reabsorption, okay, you will see the first process is filtration, okay, then you have the reabsorption, and the remaining is leftover is, yeah, if there is secretion, okay, if there is no secretion, then that substance is going to be excreted, okay, it depends really, right? Now if you want to calculate the reabsorption, okay, by all these processes, keeping all processes in mind, filtration, excretion, reabsorption together. Now you are picking reabsorption, and you see, how can I calculate the reabsorption when you have the value of the filtration and you have the value of the excretion? If both the values are known to you, can you calculate the reabsorption? Very easily. The formula of the reabsorption is filtered load, okay, minus the excretion. You'll see how much is filtered and how much is going into the urine. Their difference is actually reabsorption, isn't it? It's very simple. Filtration minus excretion, what you will get? Reabsorption. It's very simple. It's logical thinking, okay? And reabsorption will only happen when your excretion is less than filtration. For example, I give you another. Now I ask you a question. A substance is filtered, okay, and a substance is excreted, all right? Its filtration is equal, exactly equal to the excretion. How much is the reabsorption of that substance? Zero. It is not reabsorbed at all. Did you get that? Okay. A substance is filtered and then the substance is excreted. When you see the filtration and excretion, you find excretion is more than filtration. What is happening to that substance? It's secreted. But was it reabsorbed or no? It was not. It is filtered, it is not reabsorbed, but it is also secreted, and now it is going into the urine, okay, and that is another substance. Did you get that? Okay. Now we are coming to a very important concept. It's clinically very important. Concentrate. Transport maximum. Transport maximum is the maximum rate of reabsorption. Once the substances are present in the tubules, you know they are reabsorbed, and they are reabsorbed by different processes. We are only focusing active processes, active transports, okay? Active transports are controlled by the proteins or the carriers. Do you agree with me? Okay? And there are special number of carriers. Okay? You cannot increase the carriers, you cannot decrease the carriers. There are a specific number of carriers موجود in every cell. Okay? For example, 1000 carriers موجود or 2000 carriers موجود. Number is number. Okay? It's same. Okay? These carriers are working and they are causing reabsorption. Okay? If you are having, if some carriers are working, okay, the substance is reabsorbed. If more substance is coming and some more carriers are working. For example, substance is coming and 200 carriers are working. The final quantity of the carrier, number of carriers is 1000, just suppose, okay, for any special substance. The carriers are 1000, okay. Now, a substance is coming and first 200 carriers are working because the substance quantity is a little quantity. So, will you absorb that substance easily? Yes or no? Okay. Now, the substance quantity increases and 500 carriers are working. Can you absorb the substance completely and easily? No. 500, total carriers 1000. You are using 500 carriers. Will you absorb the substance completely? Yes or no? Yes. Okay, maximally, right? Now you are working with 800 carriers. Okay, more substance is coming and 800 carriers are working out of 1000. Still, is it the maximum working of the carriers? No. Is it maximum? 800 out of 1000? No. Okay. You increase the substance and now all 1000 carriers are working together. All the carriers are working. Okay. Will you absorb the maximum number of molecules of that substance when you are using 1000? All right. Now you further increase the substance. Okay. By further increasing the substance, will you further increase the maximum transport or will it remain same? What do you think? So it means there is a limit. When you are using maximum carriers, all carriers, it means you are transporting maximum substance, amount of substance. Okay. This is called transport maximum. So there is a maximum value of a substance which can be reabsorbed in 1 minute. Okay. And this maximum value will be achieved when all the carriers, you assume, you think that, okay, all the carriers, if they are working, then I can say this is the maximum value. Okay. What do you call this value as? Transport maximum. So the tubular transport maximum is the quantity of the substance that is maximally absorbed per minute. Okay. This is happening for the reabsorption. This is also happening for the secretion also. Okay. Anyway, why are we using this? What is so important about that? Okay. Clinically, any correlation? Transport maximum depends on carriers, yes or no? Okay. The substances which are diffusing, water or those sodium ions which are passing through the diffusion, do you think you can use this term for those substances? Diffusion is unlimited. You cannot stop diffusion. You keep on increasing. Okay. Active transport, first it will increase, the graph will increase and increase and increase as you increase the substance, but after some time the graph will become straight like this. Okay. This is the maximum limit reached. It is the transport of maximum substance. Okay. Now, you have a tubule system in which you are increasing the load of the substance. Okay. First the substance is reabsorbed. You are further increasing the load. This load is reabsorbed. You are further increasing the load and now you have reached the T maximum or the maximum transport quantity. Okay. It is now transported. Okay. If you are exceeding that quantity, if you are further increasing the load from the plasma, now, first of all, that quantity which is maximum will be reabsorbed. Okay. But will you have all the quantity reabsorbed or no? No. Some quantity will remain in the tubule. What will happen to that quantity? Excretion. It will pass in urine. It means if you go over the value of the T maximum, after T maximum, everything will be going in urine. Okay. And now we will consider the example of the glucose, which is very, very important. We don't care about sodium, potassium chloride because they are passing in urine normally. Okay. What we are really careful about is a substance like glucose. Clinically, we need to understand the Tm of the glucose. Okay, and see how it behaves. Now, let's see the tubular maximum of glucose. Try to understand, please. Okay. Look at this one. Glucose T maximum, please. One value is maktub for the glucose. We have calculated, we have estimated by working on the kidneys. We know that if all the carriers, theoretically, ideally, if all the carriers are equally working in all the nephrons of both kidney, okay, if you imagine that all the carriers of all the cells of all the nephrons are working maximally, then how much value will you achieve? What is the T max of glucose? 375 milligrams of glucose, if it's coming in the tubules, the load is coming, that load can be reabsorbed by the tubules without passing in urine completely. It will be reabsorbed, okay? Yani glucose is not going in urine, all of it is reabsorbed. How much quantity? 375 milligrams in 1 minute, okay? This is the theoretical situation when we consider that our kidneys are perfectly functioning, equally all nephrons, all cells, all carriers are working at the same time. But Shabab, do you think even in a healthy person like us, okay, are all the nephrons working equally at all the times? No. Are all the cells working equally all the time? Are all the carriers equally working in one cell all the time? Some carriers are slow, some are fast, okay? The rate is not equal, okay? So, will you see normally if we want to check the tubular maximum of glucose in practical life, if you want to check, will it be 375 value, a higher value or a lower value? What do you think? You will have the lower value, okay? All right? Because all the carriers cannot work. Even in a healthy person, it's a physiological variation going on. All the nephrons are not equal, okay? Some are slow nephrons, some are quick nephrons, some are okay. All are healthy, but their rate is different, isn't it? So definitely you cannot achieve 375 value. Okay, this is the experimental value or the calculated value when we consider all is good, but all is never equal in us. So, will you have the same or low value? You answered low value. Okay, how low is the value? What is the practical value of, yeah, did you see the difference? It's a big difference really, isn't it? 375 when all is very, very well and equal, but practically, normally healthy persons, taqriban how much of the value? In most of the persons, it is about 225. So you forget about that value, high value. Look at the clinical value or the practical value. What is our practical value? It's 225. It means if my tubular load is 170 milligrams per minute, do you think glucose will appear in urine? No. The load increases to 200 milligrams per minute. Do you think glucose will appear in urine? My glucose load now becomes 220 per minute. Do you think it will still appear in urine? Now after some time it becomes 250 per minute. Do you think all of it will be reabsorbed? No. Do you think some of it will be appearing in urine? Yes. Okay, so you know the point. What is the point? What is the HUD? The HUD is taqriban 225. If your load is going more than 225, that extra load, 225 will be reabsorbed and extra load will go into, okay? Did you get this concept? Great. Okay. Now come to a very important concept and then we'll quickly relate that. Now one more definition is coming. Look at the definition. We are now going into the plasma. Now we are not in the tubules. Where are we going? Plasma, yani in the blood, okay? Go out of the nephron, now think about the blood, plasma, okay? Renal threshold. You have a substance in the plasma and this substance is normally filtered in the nephron, you know that, okay? Now, plasma has a specific concentration of that substance, okay? And that substance is also filtered in the tubules. Now we'll have to make a relation. There is a special quantity of a substance which is present in the plasma, okay, at which it is not appearing in urine, all right? But if the level increases above a HUD, there is a HUD or there is a threshold value. If the threshold value of that substance changes, okay, if it becomes or crosses the threshold value, then this substance starts increasing in the tubular load and it starts passing in urine, okay? So it means renal threshold is that level of substance in plasma, it's that level, you are checking plasma, okay? That level in plasma at which the substance at this point is not appearing in urine. But if you cross this threshold, if you increase that plasma level, now what will happen? The substance will start passing in. So you are relating this with the tubular load. You are checking the renal threshold in the plasma. but you are looking at the effect of renal threshold on the urine or the tubule, okay? So if you are at the level of that HUD, at the threshold, it will not pass in urine. If you are below the threshold, it will not pass in urine. But if you cross the threshold value, the substance will start appearing in urine. As you go more and more above the value of threshold, the substance in urine will increase more and more and more. Did you get the point? Okay. So we are studying threshold because we want to know that what is the HUD, what is the threshold, after which the substance will go in urine. Okay. Which substance are we really thinking about? Again, come back to glucose. The whole issue is about the glucose, all right? Okay, look at that. Renal threshold of glucose, okay? Now this value, how much is the value maktoob here? 180. Is it present in the plasma or is it present in the blood? Or in the plasma or in the tubule? What do you think? Plasma. I'm saying threshold, okay? So what is the HUD of glucose? 180. It means if I have a level, okay, I eat food, sugar, anything, and my blood glucose now increases and it becomes like 150 milligrams, okay? Am I within the threshold or above the threshold? Do you think now my urine will contain glucose or no? Now I eat furthermore, okay, halava or something, or sweets or chocolate, okay, and my level achieves about a value of 175. What do you think about me? Do you still find glucose in my urine? Yes or no? Have I crossed the threshold or no? Not yet. Not yet. Okay. Now I keep on eating the glucose and for some reason it crosses the value and becomes 190. Okay. All of a sudden a high absorption and for some point it becomes 190. At that point, what are you thinking? Would my urine contain glucose at that time? Some amount of glucose? Yes or no? Yes. Why? Because I have crossed the threshold value. Okay, so you are linking the plasma threshold with the tubular load of the glucose. Okay, let's link it very quickly and we will get the answer. Okay, now when your plasma glucose level is 100 milligrams, okay, 100 milligrams, what is your tubular load? You know that. It is 125, isn't it? We did that. When my plasma glucose level is 100, my tubular load is how much? 125. We calculated that, all of us, if you remember. Okay. Now, if I change my, sorry for these sounds, it will hurt your ears, but I have no choice. If my blood glucose level becomes 180, which is the renal threshold value, can you calculate that at that time what will be the tubular load? What is happening in the tubules? How much is the tubular load? Can you calculate? Very simple. Very simple. Just multiply and get the answer. Okay? All right.
It's 225.
Okay, is it? Have you checked it? Logically, yes. Okay, but check it. Yes, dear. What will be the value of the tubular load? If your plasma level is 180, yani taqriban threshold level, what is your glucose load at that time? Come on. 225. All right? Okay. It means when your renal threshold is 180, at that time you are having tubular transport maximum value of how much? Tubular load is 225, and all that load is reabsorbed because your T max of glucose is 225. So all the glucose is reabsorbed up to 180. But if you change from 180 to 185 or 181 or 182, what do you think? You have crossed the threshold in plasma, you have crossed the T maximum in the tubule, and what will happen as a result? It will now start passing in urine. What do you think about the diabetic person, okay, who have a high blood glucose level of 250, 300, 350, 400 most of the time, okay? Are they lying within the threshold of the plasma or above the threshold? So what do we expect about their tubular load most of the time? Is it more than T maximum or less than T maximum? If it is more than T maximum, what do you expect in the diabetic urine normally? Usually, not normally, it's an abnormal condition, but usually what will you expect if you check the diabetic urine? What will you find? Okay, all right. You have a diabetic person, okay? Will diabetic person all the time have glucose in urine? Yes or no? No. Because sometimes the diabetic persons have a level of less than 180 in the plasma, 170, 160, 150. If it is 150 in a diabetic person, will you still find glucose in urine? No, it will not, okay? So there is no problem with a diabetic person. Only problem is hyperglycemia. Whenever he has very high level of blood glucose, it will start appearing in urine. So did you see the relationship between the renal threshold and the tubular load? If I give you the value of the renal threshold, and if I give you the value, if I give you the plasma concentration of glucose, any, and if I give you the GFR also, can you calculate the tubular load very easily? All right. And can you make a comment that it will appear in urine or it will not appear in urine? Can you tell that also? Okay. This is your clinical thinking. This is how you apply. Okay. This is not really difficult. This is the graph for your analysis. I want you at home, you will analyze this graph and ask questions from me. 1 minute, 2 minutes. Is Dr. Weil there? Assalamu alaikum. You are here, Dr. Ahmed? Yeah. Yeah. Assalamu alaikum. How are you?